Welcome, VRUSHALI.
Hi, good afternoon. Isn't this a very cute caterpillar? You know, kind of a nice color, I feel. Very rare to have such caterpillars. Is it really a caterpillar? Is it some thick friends and nice string of birds sitting together? The way you guys must be sitting on your kattas. Sayan has a katta? All right, so in a nutshell, what we are trying to say here is, the mind is going to see what it wants to see. I thought it was a caterpillar. Somebody can think that they are birds. And then the absolute reality obviously is evident after some time. After the myths of our thoughts go away, we understand what really it is. And this is what ultrasound is. Hence it is so fascinating. Fascinating in this the subject because it is totally dependent upon the person who's doing it. And hence the person has a duty of grooming himself or herself in that right till the T. So evolution of regional anesthesia has come to kind of, not an ultimatum, but yes, it has come to a very important era. Because here we are trying to become more and more objective and we are removing the subjectivity. Somebody is going to say a caterpillar, somebody is going to say a bird. No, it's not going to be so now. We are going to actually look at things the way they are in a very systematic way, and hence again ultrasound. But now here the irony is ultrasound itself is very observer dependent. So the observer has to be honing his or her skills extremely well. And hence contemplate, we have had a lot of issues in regionals, they still persist. We do have intraneural injections, we do have intravascular injections, we do have unintentional damages to various structures which we do not want to even touch with our needles, and of course block failures. Block failures are actually a complication if you ask me. In my eyes it is. So well, if we want to bypass all this, we need to be going more and more objective, more and more towards science than the art. Like fine, I did 5,000, so I know the block. Perhaps it should not be so. It should be a very systematic approach of teaching and a very, very objective way of learning it. So hence ultrasound. Now why Anila needs us to speak of ultrasound here at 4 o'clock in the evening? That's because, well, it is here to stay. We just thought that it was a fad once upon a time. It isn't. So let's groom ourselves. Why study physics? We are medical people. It's very boring for us to study physics, but quality of the ultrasound image is dependent on us, and that will depend upon how much of physics we understand. I'm not going to dwell much on definitions. I'm not going to tell you numbers. I'm simply telling you what you should be doing in your operation theaters with the machine to do your best regional shot. So the objectives of this talk is going to be to understand how that machine generates this beautiful ultrasound. What are the properties of this ultrasound? What a transducer is, what are tissue echogenicities, what is a gain, what is a depth, and ultimately, no matter how beautifully you see the nerve, you need to reach the nerve with a needle. So what is the needle and the probe relationship? And of course, LAs we know very well. So these are the objectives. So sound properties. What is an ultrasound? I'm creating a sound right now for all of you, right? So, but ultrasound is something different. It has a frequency which is far different than than the normal sound. So frequency of 20,000 megahertz and up is actually ultrasound. Medicine has chosen out of so many sounds, infrasound, an normal sound, ultrasound. Medicine chose ultrasound because it has a fascinating property of getting absolutely focused on the area that it wants to get focused upon. Having said that, how does that machine produce the ultrasound? Again, it's an extremely simple thing. If we all know what a transducer is that part of the machine which we hold in hand. The transducer has piezoelectric crystals in it. Where are they placed? They are placed at the footprint. The footprint is the part of the transducer that comes in contact with the skin. The piezoelectric crystals have a magical property. They can convert electricity into ultrasound and back. When electricity passes through piezoelectric crystals, they vibrate and create ultrasound. The signals are again then converted into electricity, and an intelligent machine is going to be there analyzing and giving us the black and white image or even color when we need it. And the other way around, of course. So this is a simple way of understanding how sound is created. Well, sound travels, and sound travels, this very sound, through different mediums in a very different manner. With solids, liquids and air, it has a different manner of traveling, and that's important because that is what gives us the image that we want to see. So ultrasound machine is calibrated for sound travel in the range of 1540 meters per second. Now, understanding ultrasound again comes to what happens with the ultrasound once we focus it on our skin or maybe in the body. So some part of it, there are some tissues in our body which is going to reflect it back, some is going to scatter, and then refraction and absorption. So again, the image is formed as per what it hits across. Pay real good attention to this particular slide. Speed, velocity, wavelength, frequency, and resolution, they all are interconnected. Everything is interconnected here. Now, if you see, ultrasound can be simply graphically represented as, say, these waves, all right? And say this particular line, a time line, a time point, say time A and B. Suppose if this is a time point, and there are 3 waves in this, all right? Fine. So this is a particular time taken by 3 waves. In that particular time, if we accommodate more waves, then what happens is we are giving a bigger frequency. The frequency is increased here, and the wavelength is hence decreased because we can have more waves, and so the time available for each wave is less. So the wavelength is pretty less here if we increase. But in the bargain, we get more information. So more the wavelength, the more the information, and hence an excellent resolution. But what is the price that we paid? We paid the price of wavelength. So it is not going to penetrate the body much, and hence it is not going to show us the deeper structures. So what we are going to see are superficial structures, but far more clearly. And we are not going to see the deeper structures when the frequency of sound increases. All right? And the other way around is also equally true. So depth and frequency are absolutely related. Lower frequencies are needed to image deeper structures, and higher frequencies limit the depth, and higher frequencies produce better image quality. So the 2 mantras here to go back home with are: higher the frequency, better the resolution; lower the frequency, better the penetration. Lumbar plexus in me, maybe go for a curvilinear probe, or maybe a straighter probe or a linear probe with a mode which is resolution. Or penetration, should it be what? Yes? Penetration, okay, because it's lumbar plexus. But a neck block in me, it has to be resolution all the time. So I have to pick up a high frequency probe. There should not be any confusion between which probe to pick up for which block. Well, now there are many other things that we can infer or decipher from this particular graph. Suppose if ultrasound is traveling at one particular speed. So if the probe is kept on my hand, the ultrasound has traversed inside and has come back. So it has taken a dip of 1 flight time, and that is actually converted into distance, and that is given to us as depth. We shall soon understand even more better what depth is all about. Well, let's come to transducers. We'll dwell upon it a little longer. What makes them different is their size, and what makes them different is the frequency that they emit. So the make of the transducer is something like this, and this is the part where the piezoelectric crystals are hoisted. In practice, in day-to-day practice, 90% of the job can be done by a linear transducer, and maybe for deeper blocks, we pick up the curvilinear transducers. So this is the transducer anatomy in detail. It actually just is enough for us to remember which transducer to pick up for what block. Now there is one important, very, very practical point to take up from here is, well, the footprint of the transducer could be of a good width, but the ultrasound that is emitted out of the transducer is just of a thickness of a credit card. So one thing about the transducer that you need to know is it emits a credit card ultrasound. If we want to see the needle very well in the plane that we are working, we need to be inside the credit card, and that credit card is emitted exactly from the center of the footprint. So that's the trick of always seeing the needle very well, no matter how you have held the probe. Well, there are two things going on right now. I am talking and you are listening. The transducer does it at the same time. It also emits ultrasound, it also listens to ultrasound. So it throws the ultrasound out, and there is a period of quiescence. The ultrasound has to come back. So again, it's one flight time which tells us what distance the ultrasound has traveled and come back, and that's depicted again into the depth, which is another way of looking at the depth. Now, broadband imaging. One person can talk in many pitches. Or if there is one person who has a low pitch, another person has a high pitch, or an orchestra, maybe a violin in various pitches. Bigger the violin, deeper the pitch. So if there are so many people all playing together, it is general mode, because in a given frequency, suppose if I've held a transducer of say 7 to 13 frequencies, so it has 7 frequencies also, it has 13 frequencies also. So suppose if I want the transducer to throw all the frequencies all together, I would go to general mode. All right, classical day-to-day example is an infraclavicular block of a well-built adult, general mode. Don't go to resolution. I'll tell you how to pick up resolution in the same. So you will have certain knob on the machine. You have to choose either the general mode. So choose your general mode and see if the image is good in this particular situation. Now come to penetration mode. Out of the 7 to 13, ask for the lower ones. So the ultrasound image is going to be better if you ask penetration, if you are using a linear probe for deeper structures. Am I confusing you? All right, yes? Penetration shall be used in a given span of 8 to say 13. When we use penetration in this particular probe, we are asking the probe to give us the ultrasound waves of lower frequencies. Maybe 8 to 10, if that helps you understand. Okay? Resolution, I am selectively asking the ultrasound probe to give us higher resolution ultrasound, higher waves, maybe say from 12 to 13. Okay? So in a 10-year-old child, an IJV cannulation or an axilla, go to resolution mode of a given transducer, of a given linear transducer. Of a given linear transducer, go to general mode in a well-built adult infraclavicular, or penetration mode in a very obese adult infraclavicular. In a child, if you want to go, maybe not a child, a school-going child, maybe 30 kilograms, want to give a sciatic, go for a penetration mode. Try doing that. For all you know, you might see it well in general mode as well. In a very thin person, want to do a lumbar plexus block, well, go to general mode with linear probe. So in me, go to general mode with linear. All right? So coming to gain, we all watch televisions, forget the definitions. Gain is something that brightens the screen or darkens it. Okay? So if you want it a little darker, use it that way. You want it a little brighter, use it that way. Gain is personal. The diagnostic people are going to use a different gain, and we are perhaps going to use slightly higher gain because we are more interested in seeing the drug around it as well. So we really wouldn't want to see a picture like this, but we would want to see a picture like this. We wouldn't want to see a picture like this as well. But we do not definitely want to see something here which is very dark. Okay, because if we want to put a drug here, then we want a drug to be seen. So our gain is tailor-made as to what we wish to do with the scan. But gains do remain personal, but there is an auto gain button on the machine which the machine thinks is appropriate for the given depth that you're working at. So far gain and near gain are two again different concepts that we need to understand. Now suppose if I have a transducer in my hand, and the transducer is emitting the ultrasound, and it is kind of getting emitted, but after some time it's not going to remain bang parallel, but it's going to funnel out. So there is some point at which it's going to funnel out and disperse a little more. Okay, so that particular point is a difference between far gain and near gain. So near gain is the one where the ultrasound has not scattered a lot, it is still quite close to each other. So that's near gain. In nutshell, why is it important for us in practice? Have the target in the near gain and not in the far gain. So have the target towards the near gain is what we are trying to say. In other words, we are asking you to centralize the target in the given screen. Okay. Now come to depth. These are all practical points. First, the first thing you will do with your ultrasound machine is of course on and off it. So on the machine. The second thing you are going to do is choose the transducer. The third thing you are going to do is assess, intuitively keep a depth, because you have a baby in front of you or you have an adult, you are going to keep an intuitive depth. And then the gain. The gain comes when you have kept the transducer and now you want to understand few more detailed things. Depth is something that you intuitively do it, and while doing it you can even eyeball it, and in a fraction of a minute you can change your depths if you want to. Well, the dictum here is again, keep a depth that will get your target right in the center. Again, if this is the sciatic nerve, let it be right in the center. Actually it is 4, the depth here is 4. Okay, it may not be 4, it could have been 3.5. I probably might have got a bigger looking sciatic nerve here. But now that I am seeing an axillary artery of a small little baby, it is 2 centimeters of depth. Now if you want to understand even further, there would be certain points here which are not so very well seen on the screen, but they would be like divided into say 0.5. So 0.5, 0.5, 1 centimeter, and so on and so forth. So 1 and 2, it gives you 1, that is 0.5 plus 0.5, 1, 1.5, 2, 2.5, so on and so forth. So you need not even go to the caliper while you are working. Your mind can actually look at the screen, and one eyeball should be able to tell you at what level or what depth the target is. Now orientation marker. If you're holding a transducer, never not know its orientation marker, because as the name suggests, it's going to orient you toward in the entire scan. So this is the blue-green dot which corresponds to this particular thing here in the transducer. Transducers will have different makes, and the blue-green dot can be replaced by some alphabet or different color. So please do not depend upon all this. Tap the transducer and understand which side is which. Right from the word go, we should have perhaps good habits, so that we never get flummoxed, because there are certain knobs on the machines which can change the position of the of the orientation marker itself, and then that gives a lot of confusion in our mind. So hence, tap it, understand it, and have one particular dictum to begin with, at least for first 6 months. Like suppose if you want to keep the orientation marker lateral all the time in transverse sections, keep it lateral. If you want to keep towards the head end all the time during longitudinal sections, do it that way. If you want to think that no, my orientation marker is going to be exactly from the point where the needle is going to enter, keep it that way. But stay that way and be aware of it all the time. Coming to tissue echogenicities, no matter how pristine your images, but if you cannot differentiate between two tissues, we cannot understand what we actually have held the ultrasound for. So we need to know which and how all different tissues look as. So all this is in relationship to each other again. Now would you all agree that in this particular scan, maybe this is the brightest line here, maybe this is the brightest one, or this is the brightest one. You all agree? Yes. So this is hyper-echoical, right? So most of the tougher tissues in the body, such as fibrous tissue, connective tissue, bone for that matter, are going to look very, very hyper. Nerve is a mixture of hyper as well as hypo, because it's going to have fascicles which are going to have some fluid in it. So they are going to look a little dark, and then these hyper tissues. So usually nerves look hyper. If I was right now very nervous, I probably would have looked very hyper. I am a KMite. Alright, so this is how it is. So one dictum is all nerves look hyper, but then there are exceptions. Which are the exceptions? The nerves which are very, very close to the central neuroaxis, such as the neck nerves. They are onion rings. They have lot of echogenicity. So let's come to echogenicity. Okay, will you agree that this is the darkest part? So this is echogenicity, no echo here, or everything is absorbed. Okay, so fluid looks like this, any fluid. Blood looks like this, fluid in the cyst look like this. Good news for regional people, even the drug looks like this. Okay, so whenever there is even CSF in a nerve to a large extent, such as a neck nerve, it's going to look dark, and then it's going to have a rim of connective tissue. So it's going to look onion ring. So lot of onion rings will come together around an artery. It will look bunch of grapes. When it goes, you know, even more distal, picks up a lot of connective tissue on the way, and it's more has more protection inside it then, and then it looks hyper, that is honeycomb. So we have lot of variations here, but the variations are only exceptions actually. Most of the nerves by rule look honeycomb. The honeycomb nerve is more forgiving because it has more connective tissue in it. Do not really needle around the neck nerve because the damage could be permanent. Doesn't mean that you should be reckless with the sciatic nerve, but she is more forgiving out of the two. Well, so now we have seen what is echogenicity. We have also seen what is hyperechoic. Now one thing remains is hypoechoic. So something that is, you know, not too bright as this and not too dark as this, something in between, maybe all these structures. So they are actually muscles. And then this is isoechogenicity, is just to complete the whole thing, doesn't clinically help us, but something which is looking totally alike is isoechogenicity. So we know how bones look. They look very, very bright. How would we differentiate it from the connective tissue? Because bones are bones, they are very tough, they do not let anything go beyond them. Okay, so that is bone. And a fibrous tissue or a connective tissue which is covering a muscle, so a fascia, is going to get the ultrasound even beyond itself. Okay, so hence whenever you see a hyper thing and a shadow underneath, which is an acoustic shadow, an artifact given because of the bone, oh, it's a bone. If you see something very hyper and still see everything beyond it, well, it's a connective tissue. Thank you, Preeti. Time, all right, all right. If you compress the veins will compress. If you, the arteries do not compress. That's how we differentiate between vessels. Peripheral nerves, they are always looked into the transverse section to begin with. And once we are very, very, you know, more accustomed to it, you can see the same sciatic nerve in a longitudinal section. Look at the catheter around it, or look at the drug spread around it, so on and so forth. So now anatomically, nerves are pretty easy to identify, but just read layer by layer, read the skin subcutaneous tissue, at least a few muscles around, and correlate it with the bone, because that is one of the good structures. And of course the artery, the brachial plexus is blessed with an artery all the time telling you where to find the nerve. The popliteal, yes, but the mid-thigh sciatic, you'll have to read the whole scan. Anisotropy, it is the best angle at which the nerve is seen. How I wish anisotropy did not exist, because it's only at one particular angle the nerve will be seen well. And you change the angle by just a bit and you lose the nerve. Doppler, by all this time, ultrasound has been focused or was focused on something that was stationary. When the object on which the ultrasound is focused now moves, such as classical example RBC, it becomes a Doppler image or Doppler effect. So what happens at that time is either the structure moves towards the probe or the structure moves away from the probe. When the structure moves towards the probe, it looks red, and when the structure moves away from the probe, it looks blue. All right. You can also put a Doppler and see the sinusoidal trace of a vein and pulsatile flow of an artery. So we can optimize color Dopplers. There are various ways of imaging. The M mode is classically used in cardiology, not much of help here. 3D is just coming up, where you can actually see the three-dimensional imaging. It hasn't yet very much proved in clinical practice as such, but 3D is coming up. There are so many artifacts that we need to know, and then well, it might have confused you till now, but there are just 4 to 5 things to remember, such as gain, depth, and which transducer to pick up. Coming to acoustic impedance, because that's something which the body gives to the ultrasound. All this time we saw what the ultrasound does to the body. It does give some resistance to it, and it's different by different structures. Let's come to practical aspect. We've discussed the orientation marker, but the needle can be given in the field of the ultrasound, either in plane or out plane. In plane is when the entire needle is seen, and as well as its shaft and the tip. And then the out of plane, you might be tempted to think that out of plane isn't that big or good an approach, but different blocks do need different approaches. But always start with in plane and then proceed towards out of plane. We do need a coupling agent in between, because ultrasound cannot travel through air. And whenever you are doing an ultrasound, see to it that you flush all your syringe and needle assembly. Air is going to sabotage your image. Once you have gained experience, you might use a little bit of air for your own advantage. Which needle to use? Any needle, any short bevel needle is good enough. There are certain eco-friendly needles coming up as well. Probe preparation, I'm not going to the video because Preeti has already kind of knocked me for the time. So
VRUSHALI,
just put a...
You have 6 minutes more.
Oh, I have 6 minutes more?
Because I have been told that they all have 30 minutes each instead of 20.
Right, okay.
So 6 more minutes.
Preeti, I thought you were my friend.
30 minutes instead of 20.
All right, so probe preparation, fine, I show you the video then. So probe preparation is, you know, just hold this by cover, the paper cover of the glove, and then put a tegaderm. The trick here is, see to it that you never have air or wrinkle on the tegaderm and the footprint. So just peel this off, and while you peel over the tegaderm, that is the time we need to be very careful of. This can be done by putting a thin film of jelly on the footprint to begin with as well. Yes, so this is the main part. So if you're good at opening wrappers of the Cadbury chocolate, you're good at doing this. Okay. Another way is wear two gloves. In one glove put a lot of jelly, the outer glove, and then hold it and then glove the transducer. So that way it's easier to work that way as well. So what suits you and your practice more, you can adopt that. Well, everyday work. So this, if you want to incorporate ultrasound in your everyday work, then you will find more and more reasons to use it as well. But then once you do that, you need to be very sure about ergonomics, because it can become tiring. You can get creaks in your back. So what you see to it that either you follow a routine of, say, the anesthesiologist, the patient, the needle and the machine. So all are in one line. Either do that, or have a proper circle where you don't have to twist or turn. Suppose if I'm giving a block here of you know, it's very easy when you have a patient in front and show that. But suppose if I want to give the right sided supraclavicular block, I would be standing at the head end, and then the patient would be in front of me, the anesthesia machine would be behind me, and then I would keep on hearing the beep of the SpO2 going on. The machine would be here, the drug trolley would be here. So I would be working this way in one go. I cannot be keeping the machine this side and work this way. Okay, so different blocks will have different ergonomics, but see to it that you are very comfortable with whatever ergonomics you take. The ambient lights of the OR would be normal, but do not on the operation theatre or rather table lights, those big lights that we usually are reflexly picked up when somebody wants to give a block. So that's the time they should be off, but once they see you doing ultrasound all the time, reflexly they will not put the lights off. Okay, to begin with, they are not going to like you. Nobody is going to like you in the theatre if you go with the machine, because the first time they see you with the machine, okay, come on, half an hour she's going to take. Then slowly, when you prove to them that your extubation times are gone, especially in adults, they're going to love you for that. All the OT staff is going to like you for that, okay. And then they will give you a special trolley. The staff will even cut the gloves and keep for you in a box. I mean, all this for over a years of time, whatever has happened, I am kind of trying to tell you in a nutshell. Well,
So now when you're just getting started, have a habit of doing a scout scan and then go and wash up, so that you know what depth and what gain to keep it at that time. Okay, and then load your local anesthetic, load normal saline to begin with, so that it can be used for hydrodissection if you are lost in between. Then sterility of the probe we just discussed. So mind you, if you are a lone anesthesiologist with an assistant, then you have to monitor the patient. That goes without saying. The standard ASA guidelines goes without saying. Now you have the machine as well. Then you have a probe on which you have put a lot of betadine, and then it kind of floats up here and there wherever you don't want it to go, so it's not obeying your commands to begin with at least. And then you have to see the needle underneath the probe, and that image has to come on the ultrasound screen as well. So there is a lot of multitasking going on, and I think women here have an advantage because we are born to multitask. All right. So this is what ultrasound is all about. You just have to begin, and then you get the gist of it. So the overview of whatever I said was appropriate. I wouldn't like anybody to leave this auditorium without understanding which probe to use, what gain to be putting up, what depth to pick up, the echo characteristics, the different imaging mode, and the needle selection. Thank you. And then the end result would be, once you really know, the end result would be the nerve is going to look at you. These are the 3 traffic signals, onion rings in the neck. So these are the trunks, and the needle is coming on its way. Here is the needle. And then you see the drug deposition in a plane which just opens up. So this is going to be your end result. You're not only seeing the needle, you can see the lumen inside the needle, and then the tip as well.
Time up.
Thank you.
Thank you so much, VRUSHALI.
Thank you.
This